Dr. Ramasamy is a fertility urologist with an impressive academic career. He has co-authored more than 400 journal articles. He is the recipient of the Gold Cystoscope Award, as well as the American Society for Reproductive Medicine and Sexual Medicine Society's Young Investigator Award. He has an NIH grant to study erectile dysfunction, and he has even published in the Journal of the American Medical Association, which is one of the top-ranked journals in the world. So a very impressive career. I first met him at a recent conference in Chicago where he gave an absolutely brilliant talk, and I asked him if he would join us on the show tonight, and he was gracious enough to accept. My apologies for the technical glitches early on. Welcome to the show, Dr. Ramasamy.
Thank you. Thank you very much for having me, and sorry about the glitch as well as the beginning, but very happy to be here.
Thank you. So we are very excited to have you on. I know at the conference you gave an absolutely brilliant talk, taking very complicated, difficult topics and breaking them down into really easy to understand ones. So would love to hear a little bit more about you, your interests in fertility urology. What made you even get into this field in the first place? And Tarek, maybe you can just turn up the volume for our TikTok viewers.
So, I mean, as I went through urology residency, I was really interested in trying to help people with their quality of life. And there was one aspect of male fertility that I thought was very underserved. Not a lot of urologists like to go into male fertility. They like to do prostate cancer and kidney stones and so on. And I thought this was a huge specialty that deserved a lot of need. And I liked helping couples get pregnant, helping achieve their fertility dreams. And I thought, what a great way to do this on the urology side, where I know there was a lot of female fertility specialists that were specializing in REI was becoming the field when I came, but not a lot of female fertility specialists was there. And so that's what drove me to specialize in male fertility and now become a reproductive urologist, and absolutely love my career choice so far.
Fantastic. So what sort of research interests do you have from the reproductive side of things?
So I think we are now researching lots of environmental impacts on sperm. People, especially with the widespread use of cannabis, I know there are a few studies that have now shown that it doesn't affect the actual sperm count and the motility, and almost implying that that people can continue smoking if they're trying to have kids in a sleep IVF or multiple ART, but that male partners won't need to stop smoking or ingesting cannabis. But we're now actually supposed to study the epigenetics. Maybe the quality of the sperm is not everything, because it has to have some impact on the quality of sperm, the sperm that's being used for an IVF cycle, and maybe its use or impacts on offspring. And so we're actually doing a prospective study now looking at the impact of cannabis on sperm epigenetics and the quality of sperm. The other important thing is so relevant for us talking today. I think the headline in the United States over the last week has been about how hot it is in the U.S. everywhere, Southwest, Eastern, Canadian wildfires affecting pollution and the quality of the air. I think global warming is going to have an impact on sperm. At some point, we're now actually at all different frontiers and fertility rates from 1980 to 2020, and have obviously seen global warming as a phenomenon that's happening worldwide. I don't think we expect with that. But the hotter it gets, and the wider variation you see in temperature. So, for example, the hotter summer and the colder winters, I think we're going to see a lot more impacts on sperm. So we're actively studying the impact of climate change, global warming on male reproduction and sperm parameters.
Wow. So just going back to marijuana, because I'm actually well known for being extremely anti-smoking, anti-alcohol, anti-drug use, including marijuana. And in Canada, of course, where we are, marijuana is now legalized.
Right.
So tell us a little bit more about the marijuana impacts. I mean, I have read studies that show that there are significant impacts on sperm quality, including motility and morphology, less so in count. But then there are also studies on the DNA fragmentation. Can you touch on that a little bit?
Sure,
That's what
absolutely.
your read is. And
Absolutely. So I think the most popular study came out of Harvard, where they looked at people who smoked versus those that don't and compared their sperm count and motility, and actually concluded quite opposite than what we've always thought, that it does not impact sperm motility. In fact, they made an argument where the sperm motility improves in smokers with marijuana. And we looked at serum testosterone levels in the enhanced cross-sectional database, and all sorts of work the price found that people who smoke the most have the highest sperm level compared to those that don't smoke or ingest marijuana. So really, completely opposite to what I've been counseling patients, completely opposite to what you've been counseling patients. And
yeah,
so we really need a good prospective study to answer that question of sperm quality in men who consume marijuana. So I think that's where we are, and I think I think we need definitive studies to answer that, because we have studies that say it's safe, and we have studies that say that it impacts sperm quality. So, but you and me, we're both on the same page. I think it does affect sperm quality. How it does, how much it impacts, I think all of those are yet to be determined.
are you enrolling in your prospective study?
So we're enrolling men who are attempting fertility, who are current smokers of cannabis. And I asked them to stop. I'm like, no, if you're going to try fertility and I'm going to help you along with your fertility journey, we ask them to stop smoking or ingesting cannabis. And for collecting sperm samples at 3 months and 6 months after they stop, and we're comparing the sperm epigenetics to how it was when they were smoking and compare it to how it is after they stop smoking.
Fascinating. Yeah. And how long have you been running that trial for? Is that just new, or have you already got some preliminary data?
We don't have it in preliminary. We collected samples, about 6 patients so far. But after we get about 10, we're actually collaborating with Sarah Kimmins from the McGill University. And she's one of these leaders in sperm epigenetics. And we're trying to see if she can help us out with doing the bioinformatics and trying to figure out exactly what it is and what the mechanism underlying the use of smoking pot is on and its impact on sperm quality.
Fascinating. What about alcohol and nicotine? Can you touch on the impact of those in regards to sperm quality, testosterone levels?
Absolutely. I think those are very clear. I think cigarette smoking, nicotine, vaping in any form, I think has been detrimental to sperm, both in terms of quality, mortality. I don't think that nobody should come to us debating, doc, can I continue smoking? And I always tell patients that come see me, this is a balance. Here I am trying to fix your varicocele, trying to improve your serum testosterone levels, give you medications to try and improve your sperm count. And here you are smoking cigarettes and drinking alcohol every day, a 6-pack beer once a day. And we're just fighting it back with that. And there's only one person that's going to win in this. It's clearly the patient and all of those habits. And so I tell them, I'm like, if I want you want me to help you with your fertility journey, this is not an option. So the smoking cigarettes and nicotine and vaping, all of that has to stop. Alcohol in moderation is okay. A lot of people drink socially. I think all of that does not affect sperm. But people who drink regularly, who think about alcohol when they wake up, when they actually have a serious problem of drinking it regularly, it will affect your testosterone levels and therefore definitely affect your sperm concentration.
Yeah. And I've seen studies that show as high as an 83% decrease in normal morphology with moderate to heavy alcohol consumption,
Right.
as well as the testosterone decreases you mentioned. So we always counsel quite, strongly for patients like you do to stop the smoking and the drinking. It is difficult, though. I find that as much as there's an incentive for patients to help themselves as they enter these journeys, and these journeys are often quite expensive, they're hard habits for a lot of people to break. So,
Talking of hard habits, I'd love to talk about obesity. I think I think that it's proven very well on the female side. I think on the male side, we have the first study that got published with premium reduction, I think last year, where they used liraglutide, similar to semaglutide, similar to these GLP agonists, where for the first time, obese men that actually lost weight on the medication, their sperm counts actually doubled. So far, we always tell patients go lose weight, exercise, eat better, every sperms. We never had any objective data to say that sperm count will improve in men who actually undergo weight loss. And so with liraglutide, I think the medicine that they used in that study in Europe, where they showed that men can improve their sperm counts, can a 50% weight loss can improve their sperm counts by twice. And so I thought that was very interesting. And I think we just make us talk about smoking, alcohol, and marijuana. We should talk about food and obesity. That often gets ignored, and I think especially with I don't know how popular it is in Canada. In the United States, people are taking Ozempic like water. It's on every advertisement.
It's getting there for us too. It's not quite in the water supply, but I think it will be soon. Yeah. It's a lot of people I use.
Every major highway will be ads for Ozempic, and I think a lot of people are taking it. And I think we are now we must going to start launching studies in men who have obesity and low sperm counts, oligospermia, low obesity. So that we offer was no medical therapy because that Clomid has an adverse effects of gaining weight, and so we can't give medications like Clomid to men who already are overweight, and we can't expect them to lose weight and improve their sperm count. So I think in that patient population who are obese, who have pre-diabetes, I think thinking about using GLP agonists and things like semaglutide and Ozempic to try and improve their sperm counts, to try and get them from IVF to IUI range, to try and get them from azoospermia to oligospermia. I think all of that will become part of routine male fertility reproductive urology practice in the next few years.
Amazing. So have you seen in your own practice, like have you started using Ozempic for your obese patients?
We have, I mean, we're now at least consulting with an endocrinologist and asking them to do it. But we talked about research and how active we are with male fertility research. Of one study where we're now starting to openly profile to include men who have people like Edward Bailey and have no sperm counts, like to see if you can treat them with some of the exciting, like she's what's like sperm count happening.
Yeah, and I certainly haven't seen any data indicating that there is a negative impact of Ozempic on sperm parameters. Have you seen anything that we shouldn't be doing it?
No, I have not. I've only seen data on people who lose weight and who don't on taking the medication. And I think the people who don't lose weight, it's not surprising, their sperm count completely.
Sure.
So no, there's no data so far.
That's fascinating. Yeah, I do think it's a huge part of what we experience, and certainly on top of the bad habits we mentioned earlier, weight is a big dilemma North America wide. I know it's a huge epidemic in the States, and in Canada we're not quite as significant as saying it's an epidemic, but it is a problem here as well. So we definitely have to deal with this. And I do tell a lot of my patients, your diet is critical. We make sure that they're trying to balance their diet, eat much more healthy, exercise regularly, get their weight down. That kind of brings me maybe to the next, best topic, which is obviously we have a lot of guys out there with low sperm counts and, they're, compromised for various reasons. What is your sort of general approach to first evaluation and then treatment for those guys? So, if a guy shows up and his sperm is showing low count, maybe low motility, low progression, low morphology, what's sort of your approach to this, aside from, hey, get rid of your bad habits and lose weight? What other sort of testing do you recommend? And then what do you start with as far as treatment is concerned?
Absolutely. So usually we start off with a good history, because I think you know this very well. The three most important factors of fertility are female age, female age, female age. So this is no longer just a man's problem. It's a couple's problem. Very different from most other specialties in medicine where we treat the patient and the patient alone. But in fertility, we always have to take the female into account. If the female is older or has female factor fertility issues and needs to undergo assisted reproduction for any reason, then usually our counseling is very different in terms of, all right, let's do X, Y, and Z to try and improve your sperm count. I think it's best that we get the female partner to a female fertility specialist. I think because of all of these reasons, I think doing ART is probably a very good idea for them. If the female is young, don't have any female fertility factors, and we do have time on the male side to try and optimize the sperm count, one of the few things that we do a simple physical exam. If there are correctable factors like large varicocele that can be fixed to try and improve the sperm count, there could be epididymal obstruction that can be fixed with surgery to try and improve their sperm count. And ejaculatory duct obstruction, we saw a guy today with azoospermia and absolutely makes no ejaculate from the seminal vesicle because of a low volume and low pH. So we could offer ejaculatory duct obstruction relief with Tourette operation to try and improve his sperm count. I think all of those things we can do on the male side if we have time on the female side. So if the women are younger, they're healthy, and they can conceive naturally, then obviously on the male side, physical examination, simple things like checking hormone levels. If your testosterone is low, to try and see how we can optimize that testosterone level endogenously, not by giving you testosterone, but endogenously trying to push your own testes to make more testosterone in hopes that the sperm counts will improve, I think are all good strategies that we do on the male side, as long as the female partner is young and can conceive naturally and has time for the male sperm counts to improve.
So in terms of improving testosterone levels in men with low T, because I know a lot of them are coming to us from family docs, and the family docs are basically saying, hey, go on testosterone, and then obviously they stop producing sperm in many cases. So what is the optimized approach from the male urological perspective to increase testosterone while facilitating sperm production?
Absolutely. So there are medications like clomiphene citrate, HCG, anastrozole, and letrozole that are used actually on the female side to try and boost egg counts, but we use it off-label in men to try and see if we can boost sperm counts and endogenous testosterone level. Exogenous testosterone therapy, mostly in the form of injections and steroids, will absolutely suppress sperm counts. I think there's no doubt about that. Unfortunately, doctors are always used to seeing, oh my gosh, your testosterone level is low. Let me give you testosterone to try and increase it. And they often don't even ask the question, if the guy is trying for fertility, does he have future reproductive needs? Are you going to have more than one child? Oh, you have one child. They make the assumption that they're going to be done with their family planning and they give them testosterone therapy. So a lot of misconceptions thinking that if I increase your testosterone levels by giving you testosterone, your sperm counts will improve. Quite the opposite, quite the contrary to what you mentioned. But I think if you do see a reproductive urologist trying to think about using medications like clomiphene citrate, HCG, anastrozole, letrozole are all good options to try and improve your own testosterone production. Taking testosterone exogenously can bring your sperm counts, like you said, to like almost zero within 2 to 3 months. And then we can reboost the system with the medications like Clomid and HCG. It'll take up to 3 to 6 months for the sperm counts to come back, at least in the majority of men. But certainly those are all treatment options for men who have no sperm and have been using testosterone and or other steroids.
At the talk you gave, again, brilliant talk, thank you. You mentioned there were certain situations where HCG might be the more appropriate choice, others where Clomid might be the appropriate choice, and some where obviously you use both together. Is there a particular time where you think, again, just for our viewers, where one is better than the other or both are important together?
Absolutely. So I think in majority of men, clomiphene citrate is a very good treatment option to start. And usually I love to start in men half the dose that we give in females. So it's about 25 milligram, which is half a tablet. And because clomiphene citrate has such a long half-life, even using it every other day without giving a drug holiday. Men don't have periods. So no drug holiday. And to just continue it for 3 months, I think is a very good option. In men who have hypogonadism, it's a very rare genetic condition where the hypothalamus in the brain does not connect with the pituitary gland and the neurons are absent. In those patients, clomiphene citrate will not work. And those conditions, using HCG alone is a very good treatment option. In men who come off of steroids, who their family medicine doctor has given it to them, their friend in the gym has given them steroids, their trainer gave it to them, and now they've been using testosterone therapy for however many years. Sometimes they started as a teenager, and they've been using it, and they don't even tell you that they're taking this as a medication because they think it's just vitamin T. And they come and they have fertility issues, and they have no sperm in the ejaculate. Those patients, I think, using the combination, both clomiphene, HCG, throw everything at them to try and improve their sperm counts, I think it's all a good treatment option.
Ejaculate. When do you feel in the fertility sort of process, is it better to go for the ejaculated sperm versus the times where we have to go for extraction, whether it's a PISA or a TESI or a micro-TESI? So when do you recommend to patients, hey, you haven't succeeded, now it's time to consider the extraction? I've been looking at the articles recently suggesting that for patients that have had IVF failures, poor fertilization, even with ICSI, from ejaculated sperm or poor embryo development, there are some studies that are suggesting that the extracted sperm may do better. And at the same time, there are others that are saying it makes no difference. What's your take on that?
That's a very good point. So I think now you're discussing how particular sperm and what happens when you get sperm from the testes. So sperm that are obtained from the testes don't have as much capability of fertilization. So if you have 10 eggs and if you have 10 sperm from the ejaculate, there's about an 80 to 90% chance that the 10 eggs would fertilize. Whereas if you have a low fertilization rate from the cycle, then using testicular sperm is not a good idea, because testicular sperm fertilization rate success is about 40 to 50%. The majority of the testicular sperm can be non-motile, and trying to use that sperm for the next IVF cycle, just remember that the fertilization success will be low. But when the embryo progression is short, meaning we had 10, 8 of them fertilized, we ended up with only one embryo at the height. When using testicular sperm and ejaculated sperm in combination is a good idea. Or you can just use all testicular sperm if you find multiple testicular sperm on the day of the use. So in some rare cases as well, they don't have an ejaculated sperm, or all of this sperm is ejaculated like that. In those cases, we don't have an option but to use only testicular sperm. Whereas in patients that have sperm and have gone through an IVF cycle, if they have low fertilization, going to testicular sperm is not a good idea. If they have poor embryo progression, then going to testicular sperm, and I usually use half and half, 50% testicular sperm, 50% ejaculated sperm, just so the couple has good options for their next IVF cycles, I think is a good idea.
Interesting. And that's true, that 40-50% fertilization rate is true even if you're using ICSI with the extracted sperm?
That's correct. Yes, absolutely. I don't think you could do conventional IVF with testicular sperm. You have to do ICSI with it.
Yeah, interesting. So so basically you're looking more at the embryo progression and the development, and in those instances it may be reasonable to do the extraction procedures. And do you think there's a significant difference between a epididymal extraction like a PISA or a TESI, or is it pretty much the same at that point?
I think at that, once you get down to the testes, I think it's pretty similar. It also depends on where you find the sperm. So in patients who are not obstructed and have not had a vasectomy, getting sperm from the epididymis with the PISA will be a challenge. In those patients, you just have to go to the testes, because if you're not obstructed, you won't get sperm from the epididymis at all. Whereas in patients who are obstructed, who had a vasectomy before, who have some sort of chlamydia, gonorrhea, and they have enlarged epididymis, you can get sperm from the PISA, and that's totally fine.
That's another great segue, and I won't keep you too long, but you're a wealth of knowledge, so we love having you here. We do get a lot of patients that come to us where they're with a new partner, and the partner previously had a vasectomy. Now, I know that vasectomy reversal success has some association with the duration from the time of the vasectomy. The number that we were clinically taught was 7 years, and that beyond that, there's so much anti-sperm antibody production that the function of the sperm can be compromised following reversal. Do you have updated information on that? What are you advising your patients? Are you telling them to skip that and go straight to an extraction and IVF, or are you still offering it to them as an option to get a reversal?
So I usually come back with female age and female factor fertility. So the new partner that the guy has married is 41. She has diminished ovarian reserve. She has the COS. I don't care if his vasectomy was 2 years ago. I still recommend them to undergo sperm retrieval, because even if you succeed with vas reversal, she on her side is going to be difficult to conceive naturally. And so I usually use female age and female factor as the decision point. If a guy has undergone a vasectomy 15 years ago and the female is 25 and she is as healthy as can ever be, she has regular periods, she's evaluated by her gynecologist, and she can conceive, even with a little bit of sperm after the vasectomy reversal, despite having anti-sperm antibodies, maybe she could get pregnant. So really, I come back to using female age and female factor fertility as a decision point in that. I've done vasectomy reversals 27 years out and the couples have conceived. But again, I am not telling you that the wife was 28 over there and she was as healthy as possible and therefore they conceived. So I think it really is dependent upon female age or female factor fertility to guide decisions on vasectomy. I use vasectomy, time since vasectomy as a landmark. I think 7 years, and then the updated data is now 9 years to have a 50% chance of successful pregnancy if it's less than 9 years. But I've sort of moved away from using that because I feel like even if I do a very good job and the female is older and has a poor AMH and endometriosis and having fertility issues, me and the guy will be celebrating saying there's so much sperm back in the ejaculate, but they're not walking home with the baby. And I feel bad that they should have really, having the walking home with the baby should be our first priority and not a successful vas reversal. And so there's more of the discussion away from time since vasectomy and more towards female age, female factor issues, and then using that to guide the decision on whether the couple should proceed with vas reversal or sperm retrieval.
Yeah, and that's a great approach. I mean, I would agree with you 100%. Well, thank you so very much for all the incredible information you've provided. Very, very happy to have you on the show. I don't know if Tarek, there were any questions for Dr. Ramasamy. Maybe we can turn to some questions if that's okay with you.